So why don't we start off? Why don't you tell us a little bit about yourself, how you got into medicine, and how long you've been practicing?
Well, I came to medicine later than the traditional route. I started my career as an electrical engineer and worked in the computer industry doing computer chip design and computer chip testing and so forth. I ended up getting into medicine. I had taken as part of grad school in engineering, took a biomedical engineering elective, and we got to work on various projects related to applying engineering principles to medicine. And these things were not super complicated, but they were very practical, like using engineering projects to identify placement of an endotracheal tube for intubation or various things like that. That kind of piqued my interest in it. And then over the next several years, I really kind of pulled me into medicine further and further to the point of me saying I should really just go to medical school. And so I did end up going to medical school. I'm now trained in internal medicine and work as a hospital medicine physician here at UC San Diego. And it was during that training in residency, actually, that I got exposure to the informatics world. I had not even known that term or field existed before residency, but we were required to do a research rotation. And I was in Providence, Rhode Island, and my program director said, well, you got an engineering background, you should look into informatics. And so I ended up sort of stumbling onto one of the hot spots in the US for informatics just because it was within driving distance in Boston. And that's where I got introduced to the field. I would say that what really sort of drew me to doing informatics as a career and really pursuing it as a research fellowship after training came really from a patient safety direction. As a medical student and resident, having had the engineering background, it struck me how, I would say, unreliable maybe is the right term, the practice of medicine was, and how ineffectively we used a pretty wide range of data at our disposal. There's one case in particular that I think solidified my desire to go into informatics from a patient safety lens, and that was a patient who came in for the complaint of chest pain, got a scan to make sure that one of the major vessels was not tearing, and it wasn't. And so he got admitted to cardiology to make sure he wasn't having a heart attack and was discharged after not having a heart attack. And so he was doing okay. However, that scan also revealed some evidence potentially of an early cancer. And then 6 months later, he arrived with widely metastatic cancer. And we looked back and said, you know, had that information that we collected at our own organization been recognized and acted upon, it's not 100% that things would have been different, but there's a good chance that his life could have been quite different. And so that really, I think, had a profound impact on me and made me feel like we need to do a better job of the information we collect.
So how long have you been practicing?
I finished my research fellowship in 2010 and have been, during the fellowship, I practiced as in the emergency room at the Rhode Island VA hospital, the Veterans Affairs Hospital. And since then, I've been working as a hospital medicine physician here at UCSD.
So you got 10 years. And so when you first came to UCSD, the inpatient record was paper-based?
When I first came here, it was a mix where all the notes were paper-based. All the orders were on a relatively old school computer-based program. And it was that combination on the inpatient side. I believe maybe on the outpatient side, they may have had electronic notes, but I'm not 100% sure, because we had an interesting rollout of our electronic health record that it spanned multiple years where different phases of our healthcare system went live at different points. But it was until, I think it was 2011 I believe, that we went live with the inpatient, sort of the more comprehensive inpatient electronic health record.
Okay, and then when your different training hospitals, when you were in medical school and residency, were they all electronic or kind of a blend?
It was a blend. The Veterans Hospital was electronic, and the other two hospitals that I worked at were similar in that we would do paper orders, paper notes, and then computer orders. Is that true? Actually, no. I think we may actually have done paper orders at that time as well. Actually, so it was all paper.
Okay. So, what's kind of describe what kind of kind of like your typical day case. What are the different kinds of data that you're monitoring? How much are you responsible for collecting, or just kind of reviewing? And what are some of the different major sources of data?
I guess maybe I'll walk through the life cycle of a inpatient admission, maybe. So when when we first admit patients to the hospital, we are typically what happens is we get called from our emergency department and says that this person is here, has a condition that warrants inpatient management in the hospital. And then we go down and we start talking to the patient to try to get an understanding of exactly what's going on. And so we do get, so speaking of data and the sources of data, one source of data is the verbal communication with our colleagues in the emergency department, where they essentially frame a conversation about what the patient has and what led them to the emergency room and why they're trying to make the case of why they think the patient needs to come into the hospital. And I'll start with that it's a challenging, sometimes very challenging, to get a clear story because our emergency department, like many, I think, there are relatively frequent changes in the primary care teams, or the teams in the emergency department, due to shift work. And the stays of our patients oftentimes span at least one of those transitions. And so by the time the patient is ready for admission to the hospital, the conversation may go something like, well, I wasn't the person who initially did all the workup, but this is what I was told about what was going on. And then you ask a few follow-up questions and they say, I'm not 100% sure because I wasn't here when they had that conversation. So you're already kind of starting at a deficit of information. And so we oftentimes repeat a lot of the questioning and when we meet the patient, in which they almost invariably get annoyed by the fact that they already told at least 3 other people the exact same story, and why are we asking them again, and so forth. So when we do that assessment, obviously taking the history from the patient, doing a physical examination, but a lot of that also involves understanding the patient's context before they got into the emergency room. And so that's reviewing records within our own organization, but increasingly reviewing records from other hospitals, or either within our region or even elsewhere around the country that may contain pieces of information about the patient's medical history, previous treatments, and previous diagnostic tests, and so forth.
So it sounds like you have a functional health information exchange down there right now.
I mean, it's pretty functional. I mean, well, it's functional, not as robust as, say, what our Veterans Hospital does, which is really complete record exchange between the Veterans hospitals. Oftentimes we will get snapshots or overviews that are transmitted from one hospital to another that say, medication lists, maybe a list of medical conditions. More and more, especially within organizations that use our same commercial electronic health record vendor, we will get increasing amounts where we have lab data, clinical notes even, and so forth.
How good are, well, an emergency, patients, that's a little different. They might be under acute stress, haven't had time to reflect or gather, their notes before they showed up. How reliable are patients at, I suppose, saying how they're feeling right now, that's, but describing their medical history or their family history, is that ever problematic?
That is often problematic, and understandably, because like you said, I mean, these are patients that are usually have an acute medical issue, and it's a challenge to try to recall details that are, you know, years gone by and so forth. This becomes, you know, one clear manifestation of that is, say, the patient's medication list. And you'd think that from an information standpoint, it's a very well described, tell me the medication, what dose, when do you take it, and so forth. You'd imagine that that's maybe one of the more, I guess, bounded questions that we ask. But it's very challenging, actually, to get an accurate medication list for a patient, especially when they span multiple different organizations. The patients oftentimes, when their medication list becomes, you know, greater than 4 medications or so, have a real challenge remembering all of the details of each of those medications. And I think the irony of it all is that once the records got computerized, the refrain is often, well, I mean, you have that list in the computer. And their assumption is that we know the right list. Our assumption is that they know the right list. We all recognize in the medical system that very rarely do we actually have an accurate or complete list. And so the real question is, who's got the actual answer? And it's really kind of distributed probably across multiple places. Even when we call the patient's pharmacy, until very recently, the pharmacy would only understand when you added a medication, not when you removed it. And so you would get conversations such as, well, they did not fill this for the past, you know, 6 months, and they were refilling it at 90 pills a time, so they're probably not on this medication anymore. And so you're trying to kind of piece together a medication list through this sort of piecemeal fashion. So anyway, the short answer is, oftentimes these questions require repeated questions over time to kind of fill out the picture, because any given point in time, the patient probably I think it's maybe too much to ask for them to give a complete history during the time of an acute illness like that.
Yeah, you know, I've taken 2 medications for 20 years, and I just kind of I could probably repeat those in my sleep, but I'll come on and off of things for a while, and you know, I may not be that interested in them, or you know, I talk with my physician and we talk about the name brand, and then when I get the prescription filled, you know, it's a generic with some other name on the box, and I just don't pay attention to, you know,
Right.
and I guess I just assume, well, if I really need to, I'll look it up on my phone, which hasn't been as easy here in Australia as it was in the U.S. So one thing that's, I think, worldwide, hospitalizations, there's a push to decrease hospitalizations, make hospitalizations shorter. That's actually the opposite here, Australia, and it's, I think, largely funding, you know, perverse incentives. But hospitalizations are going up in Australia with respect to the rest of the world. What's kind of the trend for how long someone is in the hospital? And are there pressures to try to keep people out of the hospital? And what's kind of the dynamics of that?
Like you had mentioned around many countries, I think there are real attempts to make sure that people are in the appropriate level of care and not overly treated, not undertreated, and a growing amount of evidence that things that physicians were maybe nervous about trying to do as an outpatient are likely safer than we think, as well as the amount of technology to support more monitoring in the outpatient setting is potentially easing people's anxiety about having people treated at home. I think in general, the trend is to treat more and more as an outpatient for a variety of reasons. I think that cost being maybe a primary driver in terms of the amount of overhead it takes to take care of somebody in the hospital. Although at the same time, you know, the recognition of how the real risks, I mean, there are clear benefits from being in the hospital, but there are clear risks from being in the hospital as well. And so from a patient safety and I guess health outcome standpoint, there are real incentives for treating people outside the hospital as well. And I think that trend is going to continue You know, and we feel, and maybe it's just, I don't know, maybe we just think it is as we're getting older, but it seems like the patients who end up in the hospital, given that model, tend to be selected as even more and more complicated and sick, because the simple things that used to be hospitalized are now being done as an outpatient, and therefore the people who end up getting admitted tend to be pretty complicated.
We have some neighbors who just had a baby, and it's their second baby, and she was saying that the standard post delivery hospital stay here is 5 days, which just kind of, I think I know my Wendy would be going crazy if she'd been in there 5 days.
Yeah, it's much. Yeah, I can't imagine that ours is anywhere near that, but I'm not positive.
Yeah. So one of the things that the students will do later in the semester is kind of, have some opportunities to browse through Mimic data set, which is an ICU data set. How different, and I guess the waveforms are all kind of, a separate thing, but how different would a patient in a hospital, in a non-ICU ward, look on a data perspective than what like one of the Mimic, say like a DRG1 kind of, not a really complex case. How different would their data set look than what a Mimic data set ICU patient looks like?
I think there are a couple big differences. I guess the first one just being the intensity of data collection and the frequency of data collection. Obviously, the waveforms are being updated all the time, and that's a pretty high volume of digital data right there. That's more so in the intensive care unit in terms of the number of waveforms and the type of data. That same data, and a fair number of those data points are also collected outside the ICU, just much less frequently in terms of vital signs, blood pressure, temperature, heart rate, oxygen saturation, and so forth. But you can see that it's much more spaced out. I think that the nursing assessments, one of the reasons you're in the ICU is because you need very close and frequent monitoring, and so the number of notes being written by nurses, I think, is a lot higher. And the various flow sheets, at least in our construct, the flow sheets where you basically tables of data that the nurses can fill out about various types of assessments, is much more frequently populated. I would say also in terms of the acuity part of it is sort of double-edged in the sense that on the one hand, there's very acute issues that, it's life-saving and require a lot of specialized attention. At the same time, there are non-acute issues, but maybe important issues that tend to not be addressed as aggressively in the intensive care unit. And therefore, on the non-intensive care unit floors, once they come out of the intensive care unit, some of those things get kind of addressed more aggressively. For example, some of the, diabetes, for example, or some of the other, chronic but maybe not well managed conditions become a little bit more apparent as you have a little more time with the patient outside the ICU, and they get more attention in the clinical notes and so forth.
Outside of the ICU, is there any data like device direct to EHR data flow, or is it all kind of charted by a nurse or a therapist?
That's a great question. I believe that our monitors now are still, it's essentially a data flow. I believe that they're going directly from the monitor to the EHR with a validation point for the nurses, so that they can make sure that it wasn't, some patient with a heart rate of 300 because they were brushing their teeth or something like that. But yeah, so I think there is that part of it where there's some facilitated data entry. So it's not, you have a little bit less transcription opportunity for transcription errors. And I think some of I'm not positive, but I think some of the pumps for intravenous medications may be connected, but I'm not, that may still be kind of in the works.
Okay. So what are some of the kind of like tools that you use? Like, I think you're the one that introduced me to UpToDate. And I'm like, so to what extent are you like completely digital, or you are like scribbling notes on paper whatever. Just kind of describe how you're dealing with that.
Yeah, I think that for a single day, I have one sheet of paper that I print out. Basically, I have a patient list, and this is maybe a hospital medicine workflow that I'm describing. So it's not true of all providers in our system. But I have one sheet of paper that I print out that has the patient list at the beginning of the day. And then I just kind of, through our electronic health record, make a grid that essentially allows me to make a, to-do list or check boxes for all my patients. And from there, I add on additional patients that are handwritten. But this becomes essentially my sort of central place where I make sure that I don't forget to do something for the day for each of those patients. So it's things like, did I write the note for that patient? Did I put in all the orders for the next day for that patient? Did I do my billing for the patient? And did I update the information that I'm transmitting to the colleagues that watch the patient overnight? Did I accurately, update that to make sure that they're following up on whatever they need to follow up on? Other than that, essentially everything else has been digital. And so tools that I use, I mean, I guess, UpToDate, I don't know if UpToDate is in Australia even, but I think that essentially, yeah, so your students likely know about it, but it's, a curated sort of, I guess, synopsis or summary of current evidence on a variety of clinical topics. And so we all recognize that nobody's keeping up with the literature on everything. And so it allows you from the point of care to say, okay, well, here's a particular scenario. What is the latest recommendations as far as like treatment and dosages of medications and various other things like that? I would say that just this last week when I was in the hospital, I found out that the recommendations from our infectious diseases, society in America had changed for the empiric treatment of a particular condition. And I initially, prescribed the one that was there 6 months ago. And now they're like, no, you know what? We're going to update that to the new one because, that's the new recommendations and so forth.
So was that the pharmacy? Was that like feedback from the pharmacy?
That was feedback from an infectious diseases doctor, actually. But it would have been had I looked it up in UpToDate for that, then it likely would have referenced the latest guidelines there. So that from a knowledge standpoint, clinical knowledge and recommendations, UpToDate is pretty widely used for many sort of real-time decision making or real-time literature reviews, I would say. Other tools that I think are really important, and I think that start to take advantage of having an electronic health record, although we're definitely not 100% there, are some of these condition-specific data aggregation screens within our electronic health record. And so things like, particular scenarios where this becomes important. So inpatient diabetes management, where we try to keep people's blood sugar when they have diabetes under control and not out of whack within the hospital. Oftentimes we, stop all their oral medications and put them on insulin while in the hospital, and trying to get the doses right so that the sugars don't go too low, but they don't go too high, often requires day by day modifications. And so having a summary screen of looking at how much insulin was required over the past couple of days, what did that do to their values of glucose throughout the entire day, and making adjustments like that, it's been very helpful. Similarly with pain medication and trying to understand, we want to kind of minimize pain medication while making sure that people are not sitting there in pain. We use something similar where we try to understand what is their requirements that they've needed over the past couple of days, so we can adjust their regimens accordingly and so forth. And there's other examples like that. But I think those types of, I guess, clinical condition-specific summaries tend to be very helpful. They're a combination of automatically pulled from the electronic health record, but designed oftentimes by the clinicians to make sure that it makes sense and they're kind of in the order and collecting the right information. They've been very helpful.
And then finally, has COVID changed anything in your life yet?
COVID has changed a
Clinical
lot.
life.
Yeah, COVID has changed a lot on the clinical workflow side. The way things had worked maybe for over a century is that, you know, our team goes around to the different rooms, and you know, we will stand there either in the hallway in front of the patient in the room, and the medical student or the resident will present the case, and we will have a brief discussion about what's going on with the patient involved, oftentimes, and have some conversations about what we might want to do, either diagnostic plans or treatment, or are they ready to leave the hospital, and so forth. And because of COVID, there's been a pretty significant change over the past many months now, where essentially we are all sitting in a room by ourselves, talking about all these patients, trying to strategize how do we make sure the patients are seen adequately, but we don't both expose the patients to too many providers, the providers to too many patients, and especially if they are COVID positive or unknown at this point. And so it's changed a lot when it comes to the interpersonal connection between our providers and our patients. It's also pushed us, like a lot of places, to aggressively adopt some telemedicine tools, both on the outpatient side, where I think it's very much used, but increasingly on the inpatient side too, where we say, I've seen this patient with COVID. I had a COVID patient, positive patient that I saw in the morning, and then I wanted to follow up and see how they're doing, you know, in the afternoon. Due to both the exposure risk and the fact that we need to use up gowns which are in short supply, we wanted to potentially just have them a Zoom meeting like we're doing right now, even though I'm only like one floor above them in the hospital, you know. And so I think those types of things have changed quite a bit in terms of the way that we interact with our patients, and showing us kind of what we're missing, essentially.
Okay, one piece of advice you want to give informatics students?
One piece of advice. That's really a lot of pressure to say something meaningful, man. I mean, I think the biggest piece of advice, you know, that I tend to give, especially those interested in clinical informatics, is that even the best laid plans and best systems oftentimes break when you're in the real world. And so I think that the biggest piece of advice I would have is that if you're planning on something that is going to be used in an actual clinical setting, that you involve people from that clinical setting very early on in the process. It'll save you a lot of time and a lot of headache, and it'll definitely increase your chances of having a successful and higher impact from your project, because you won't sort of hit roadblocks from sort of things that seem kind of ridiculous, but are the reality when it comes to real clinical work. And that I'm definitely speaking from experience, because I had several projects that essentially were complete failures because of some weird workflow thing and that type of thing. So definitely it'll be in your best interest to do that.
All right. Well, thanks for your time, Rob. Look forward